Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of welcoming back to the podcast Dr. Floriane Jochum from the Institut Curie and also from the University Hospital in Strasbourg. The reason for this podcast is a publication in The Lancet titled A Reproducible Framework for Monitoring the Impact of Randomized Clinical Trials on clinical practice using large-scale real-world data, application to gynecological surgical trials using the French National Healthcare Database. Florian, welcome back to the podcast.
Pedro, thank you very much for having me back so quickly for our second podcast. I guess I can't say anymore. It's been a long time, but it's a pleasure to continue this conversation and discuss about this second research project.
Yes, absolutely. We're so proud of you. And of course, obviously, you were a fellow in the journal. And again, now, so proud. You're now in the Lancet. So congratulations. So really interesting study. What were the reasons for this study and where did you see the scientific value in this project?
Well, this study addressed an important gap in understanding how randomized trial actually influence real-world clinical practice. As you know, randomized trials are the gold standard for evidence-based medicine, but uh, we didn't have a good way to track if their findings actually change what happens in clinical practice. So we wanted to develop like a framework that could systematically measure the impact of these trials across different healthcare settings using large-scale administrative data. We use causal inference method, and with this, we actually can quantify how effectively trial findings are implementing to routine practice, and also try to identify disparities in adoption patterns and understand institutional characteristics that influence implementations.
Yes, absolutely. From those of us who have run prospective randomized trials, we certainly hope that it does change and impact practice. So now getting on to my next question, and I know that we covered this in a previous podcast, but for those who might not have access or heard that previous podcast, what is the French National Health Insurance Database and what does it capture?
So the French National Health Insurance Database is a large-scale administrative database covering about 99% of the French population, so around 70 million people, and it tracks healthcare encounters since 2010. It captures three main categories of information: demographic data like birth, sex, residence, but also hospital data, so diagnostics, medical and surgical procedures, and all about outpatient care, so the medications, the lab test, and medical procedure outside hospitals. What makes it useful for research is that we can link all these elements longitudinally, and we can follow all the patient's journey through the healthcare system over times. It does, of course, have some limitation. We don't have all the detailed clinical information like tumor staging or pathology results, but we can use algorithm to try to identify the patient and identify all the characteristics and find all the information actually we need.
So Florian, what was the aim of this study, and can you share with us a little bit about the methodology, and particularly if you can speak about why did you use these two time frames to evaluate radical hysterectomy and ovarian cancer patients?
So the goal was to develop frameworks that everybody can reuse using real-world data to systematically assess how major randomized clinical trials influence medical practice. So we apply this framework to two pivotal surgical trials in gynecologic oncology. So the laparoscopic approach to cervical cancer and LION lymphadenectomy in ovarian neoplasm. So the methodology involves 4 steps. First, we curate the cohorts from the French National Health Insurance database. So one cohort with a patient having radical hysterectomy for cervical cancer, and another cohort with patient having cytoreductive surgery for ovarian cancer. Then we employed the Bayesian structural time series analysis to estimate the effect of this trial on surgical practice. Then we stratify the results by institutional characteristics, so like academic status, research mission, domain expertise, and resources. And to finish, we calculated the immediate and cumulative impact on practice pattern. Why we use these time frames is that we needed to have clean cohorts with all the right selected patients, the right selected outcome, and we needed sufficient data before and after the publication of the trial, because we need to have the effect. We need to have the trend before the publication of the trial, and after we need to have some years to see the time to have see the effect of the publication of the trial. So it was like 5 years before the intervention for the LAC trials and 4 years after the intervention for the LAC. And for the Lion trial, it was 3 years before and 5 years after, but it was only because we have access to this time frame for cervical and ovarian cancer.
Yes, well, I also want to thank you for selecting the LAC trial as part of your analysis. So looking forward to further discussions. But I wanted to also now ask you, you specifically focus on this study on the type of center and their institutional indicators. Can you tell us a little bit more about that and what type of indicators were you focusing on?
Yeah, we focus specifically on center-specific indicators because we saw that previous research suggested that the translation of randomized clinical trials findings into practice could be significantly influenced by organizational characteristics, and it belongs public and private and academic and non-academics. That's why we wanted to analyze more specifically the impact of the research and teaching missions, and also the oncological and surgical expertise. And to do this, we calculated a score with 32 variables about all the activities, about the oncology, the radiotherapy, the surgery, not only gynecology, but after digestive, urologic, so all multidisciplinary surgical resources, and also about support activities like palliative care or everything we need for oncology. We also analyze human resources because we know that if we are not enough to do the hospital duty, but we cannot go to the congress, or we can stop the knowledge of the new research. And also we look at financial condition, but only for public hospital because we didn't have the data for the private hospital. So we analyze all of this to have more nuances, institutional characteristic, and to see which one exactly impact the translation of randomized clinical trials on medical practice.
Excellent. So this next question comes from Alicia Yates at Houston Methodist. And she's asking, can you tell us specifically why did you decide on the LAC trial and the Lion trial?
Well, we choose the LAC and Lion trials for specific reasons. Both were really practice changes studies. LAC trial questioned minimally invasive surgery for cervical cancer, and why Lion challenged routine lymphadenectomy in ovarian cancer. They really offer like clear choices. So it was minimally invasive surgery, yes, no, and lymphadenectomy, yes, no. So it was very straightforward implications. And also the timing was very good because we, as I said before, we need data before the trial to see the trends. And we also need data after the trials, the publication of the trial, to see the evolution and to have enough statistical power to detect meaningful changes. So these trials represent different types of change also, because like requiring adopting a more demanding approach, because it's more difficult to go for minimally invasive surgery to laparotomy, while lion only a little, only, while lion requiring omitting a standard procedure, so it's more easy to do. That's why we choose both this trial.
Okay, well, thank you again. Now, this question comes from Thomas Bartel at the Medical University of Vienna, and he's asking, how did the authors decide which variables to include in the expertise score for each center? Why did the authors decide that an expertise score may offer a better estimate of expertise as compared to just like the number of respective interventions in ovarian and cervical cancer? Is there any validated data how the variable number of post-interventional surveillance rooms may indicate center expertise?
Well, when we wanted to analyze the expertise, we could have just used annual procedure volumes, but we thought that institutional capability in cancer care involves more factors than only the volume of center. So that's why we selected this variable to see all about the infrastructure, to see the data about the specialized oncology units, the radiotherapy capabilities, and all about supportive services. Variables like number of post-interventional surveillance rooms were included because they reflect the center capacity to manage complex cases, surgical cases and complication, and it's actually an important aspect of expertise beyond the procedure counts. And so that's why we use all these different data, and we did validate it on the center in France to see if the ones that were supposed to be the most expert was well identified by this expertise code. Yeah.
Right. So now, Floriane, let's get to the results. What did you find? What were the highlights of your study?
So we analyzed 7,000 patients with cervical cancer and around 20,000 ovarian cancer patients. And we had almost 600 centers in France. So what we find is that the LIKE trial led to a 14% reduction in minimally invasive surgery overall. So it's make like 275 fewer surgery than expected without the trials. So thanks to the LIKE trial, almost 300 patients was not operated by minimally invasive surgery, but was operated by laparotomy for the radical hysterectomies. Academic center reduced their minimally invasive surgery by almost 28%, while non-academic center increased use by 2.5%. For the LION trial, we saw a 23% overall reduction in lymphadenectomies. And so thanks to the LION trial, there was more than 2,000 patients who didn't get lymphadenectomies due to this trial, so it's quite a lot. And academic center reduced lymphadenectomies by 31%, and while non-academic centers achieve 15% reductions. So we observed timing difference between also academic and non-academic, especially with the LION trial, because we saw in the LION trial that the non-academic was actually also doing a reduction of the lymphadenectomies, but there was a time the observed practice changes make waiting a lot of until a month after publication compared to academics. So we also find that center with research activities, high expertise, and adequate resources implementing change faster and more completely. And we find that removing a procedure like in the Lion seemed easier to implement across centers compared to switching to a more complex approach like in the LAC. And this suggests that the direction of practice change affects how easily evidence is adopted.
Yes, absolutely. And how comfortable you feel with the results of the study as well. So let's start with my first question, which obviously is the obvious question. Why are academic centers adapting results of major randomized trials and non-academic centers seeming to dismiss these results? What is it about the surgeons in one place versus the surgeons in the other?
Well, I think there is several factors about this. The first logical thing is that academic surgeons are typically connected to research networks and attend international conferences where trial results are first presented. So they receive the information months before publication, and non-academic surgeon often encounters new evidence later when it appears in journals or in the guidelines. And also, many academic surgeons participate in clinical trials themselves, creating a culture that values evidence-based changes. They often have established a mechanism for updating protocols when new evidence emerges. And quality improvement processes are also a factor. Academic centers usually have regular morbidity and mortality conferences where new evidence can be discussed. And specialization plays a role too, because academic surgeons typically focus on one specific cancer types and make it easier to modify their approach to particular procedure. And non-academic surgeons often have maintained a broader activities, making it harder to track specialty-specific evidence. And of course, there is also financial condition. I guess it is more difficult in non-academic center to say no to minimally invasive surgery and to go back to laparotomy. It's a complicating question, I think.
Well, as a follow-up to that, Stephanie Gill from the University of Toronto, she's asking, in France, are only gynecologic oncologists versus a general gynecologist or a general surgeon performing these procedures, regardless of the type of center? Was this data captured here?
So it's only like gynecologists, obstetricians who do the procedure. But when we work in an academic hospital, we do specialize in one type of surgery, so oncology or functional. So at the end, we became more experts in a field, but we don't have a specific specialization like we have in other countries. Yeah.
Okay. This question comes to us from Matteo Marchetti, and he's asking, the observed decline in the use of minimally invasive surgery for cervical cancer by only 14% and the omission of lymphadenectomy by just 22% is striking, considering that the results of these groundbreaking randomized trials were soon incorporated into major guidelines. Given that both cervical and ovarian cancer require complex management and that guidelines consistently recommend centralization in high volume oncology center, wouldn't it be more effective to focus on enforcing the centralization of these cases in specialized centers where treatment approaches are really up to date, rather than solely improving the dissemination of trial results in non-academic institutions?
Yeah, actually the disparities we observe, yes, of course, raise questions about whether centralization or better dissemination should be prioritized. With minimally invasive surgery for cervical cancer dropping only to 14% in lymphadenectomy, decreasing by 23%, with significant difference between center types, there is, of course, room for improvement. We find that for cervical cancer, they have more than centers that are performing cervical cancer, and for ovarian cancer, we find more than 500 centers. For a population of about 67 millions, it's actually quite a lot, and we are really far away from the centralization. Personally, I think we need both approaches, and that it applies differently for the type of cancer and the type of surgery. For complex cases like ovarian cancer, yes, I think centralization makes sense, and actually now happening in France. The technical complexity of cytoreductive surgery, the high complication rates, the need for intensive care after the surgery, all of this makes that we need to do centralization and having treated this patient in specialized centers. But like for more common cancer, maybe like endometrial cancer, I don't know, for cervical cancer, I didn't make my choice already. But like for endometrial cancer, yeah, I think complete concentration would limit access, and we will need a better dissemination network to help like a center who have a lower volume to help them have the good practice and to know what is the new recommendation. So I think we need both. For cervical cancer, I don't have the answer yet because it's we don't have a lot of radical hysterectomies. So I think for the surgery, it may be centralized, but it may be cause a problem for the accessibility. So I'm not sure about this yet. Yeah.
Okay. So now Thomas Bartel from Medical University of Vienna, he's asking, traditional time series forecasting typically assumes stationary data. However, it seems that both the mean and the variance were already functions of time in both trials before the publication of the LAC and the LION. Could the Bayesian approach help address the potential violation of the assumption that the relationship between surgical practices may not have remained stable from pre to post intervention periods?
So yes, when we examine the data, we noted that the traditional time theory will not work. It will not be inadequate because the surgical volumes were changing before the trials were published, and we have not really stationary data. And actually, we never have stationary data in time theory analysis. That's why I love the Bayesian model. So we chose this model because it offers the advantage that we don't need to have stationary data for this model. It models the complex patterns in the pre-intervention period rather than assuming simple linear trends. So it incorporates like the uncertainty at multiple levels, and we don't care if there was an unstable baseline before. And so yeah, he has other assumptions that we need to be sure, of course, that there was not another intervention that could explain the relation. But the assumption of this model are well easier to complete them. And that's why I don't like normally the traditional time series analysis because we never have stationary data.
Great. So now let's go to a question by Elise Yates from Houston Methodist, and she's asking, what important considerations should be kept in mind when interpreting results of a study using reproducible framework?
When interpreting results from this framework, of course, there is several consideration. So as I said, there is other assumptions that we need to take into account for this causal inference. So our causal inference relies on the assumption that the pre-intervention relationship will have continued without the trial publication. So if the minimally invasive surgery was going up slowly in the non-academic institution, we make the assumption that it was going to have the same trend if the trial was not published. In our study, it's this assumption. Yeah, I think we don't have a problem about this, but we need to remember this if you want to assess another trial, or maybe it's not the cases. Also, we need to have implementations. There's are another consideration. So some centers adopted findings after significant delays. With shorter follow-up, we might misclassify the delayed adopter as non-adopters, which is why we use an extended observational period. So we need to be sure that we have enough time before and enough time after to make the right conclusions. And also, we need to know that administrative data has limitations, so we need to be sure that we can identify the same population as in the trial. So we need to be sure here to identify the patient with radical hysterectomies with cervical cancer and the patient with advanced ovarian cancer with cytoreductive surgery. And we need to be sure that the procedure code capture well what we want to study. In our study, our algorithm for patient identification was clear, and we didn't have a problem about this. But if you want to reproduce the same with the other trial, we need to be sure we can reproduce the exact same selection and the exact same identification of outcomes.
Yeah. So Florian, now, of course, obviously, we see how meticulous you are about methodology. Obviously, high scrutiny in terms of articles published in the Lancet. But what do you see as weaknesses of this study?
Well, the major weaknesses of this study is that we use administrative data sets that cannot capture everything. So maybe we have some information that might influence the surgical decisions. Like, for example, maybe one of the patients had lymphodectomies in advanced ovarian cancer because they find a lymph node, or because they knew that there was a lymph node that was supposed to be removed because it was malignant, and I didn't know about it in the administrative data. So I said, oh, okay, this center did a lymphodectomy, but it was not supposed to. But in reality, yes, it was a good indication. And our causal inference framework also assume no other major policy changes or clinical advances occur simultaneously with this trial. I don't think we have a major changes in guidelines or trendings that could explain the difference, but we need to remember this. But yeah, I think that's it for this study. For one time, I can say there was no major weakness on this.
Of course. So, Florian, as a last question, I routinely ask the authors, how do you think your findings are going to impact our care, or, certainly the concept that we previously brought up of centralization in healthcare systems?
Well, the first thing is I hope many people now are going to use this framework, but because I really think that we really need to systematically check what was the impact of the randomized clinical trial, and was it followed, and where was it followed, where was it not. I think it should be systematically, and we should create like a group that analyze every year if the new evidence are applied or not. And also, I think we need to think about how to do the centralization of care, but also how to implement a network with all the hospitals to try to improve the homogenization of care, and to be sure that every patient have the right care. And I think it's the job of the academics to try to give the right clinical practicing and the right guidelines to the hospital, to the regional hospital, to help them do the right practice. Yeah.
Fantastic. Floriane Jochum, congratulations. Thank you so much for accepting our invitations and really very, very impressive work. We're so proud of you. And once again, thank you for the contributions that you're making already very early on in your academic and professional career. Really very impressive. Thank you.
Thank you very much. Goodbye.